Hey everyone, so in this video we want to discuss how we assess ankle dorsiflexion and ankle plantar flexion and some of the movement compensations that you might see. Now when we say compensations are a very normal feature of human movement in the real world. Because we're moving in a very variable environment, we need compensation, we need a distribution of workload and movement across the anatomy. That's how the anatomy is designed, to distribute workload, to distribute forces. Okay, so when we say compensations, it's relative to a normal movement, if you like. Now, in this scenario, we're trying to concentrate that variability at the ankle. Okay, so a compensation would be represented by an inability to concentrate movement or to express variability at the ankle, and a shifting of mobility or movement or variability into a neighboring segment. Okay. So when we're looking at ankle dorsiflexion, we're looking at that as a representation of how well we can manage forces, distribute forces. When we collide with the ground, we want an adaptable foot that can distribute forces, redirect forces over a broad surface area. If we land with a very rigid foot, that reduces the space or the options that we have to distribute forces. We want a wide range of options to manage forces. We're looking for a pronation bias. We're looking to see how the tibia might help facilitate that ankle dorsiflexion, which wouldn't be honest ankle dorsiflexion, as you'll see here in a moment. But when we're looking at coordinative strategies, particularly when they look at it in the research, they use certain techniques to assess the interaction between individual segments to represent the variability of our movement system. And what you'll see here in a moment is an in-phase strategy that they describe in the research, which would represent the movement of neighboring segments into the same direction, which would represent a lack of variability because we don't have that dissociation capacity, that relative movement. So when both movements are moving in the same direction, it's like if I just took my arm here and I internally rotated my humerus to internally rotate my forearm, there's not really much relative movement occurring between the forearm and the humerus in that scenario. It's moving in the same direction. So there's no variability at the elbow, at the humeral and forearm interaction in that scenario, if you like. Okay. Similar kind of scenario in the foot and the ankle. So we're looking at the interaction, the general interaction between the tibia and the foot segment. We can look deeper into the within foot variability between the rear foot, midfoot, and forefoot. But when we're measuring ankle dorsiflexion, ankle plantar flexion, generally we're looking for we're looking at the tibial and the foot interaction. So we'll pull the ankle dorsiflexion assessment up here on the full screen. That into HD, and then what we're looking at here is we're looking at a closed chain assessment strategy here, where that dowel is about 10 centimeters away from the big toe. We want the client to bring the tibia over the second toe to touch the dowel. So think about you're generally trying to keep that tibia in the sagittal plane. You're looking for the knee to be able to touch the dowel, and you're looking for a little bit of pronation at the foot. You're looking for a dropping of the arch. Okay, because we need that talus to adduct or move immediately to bring some motion back into the ankle there. Okay, if we're too supinated or externally rotated at the foot here, that's going to reduce that capacity of the tibia to move over the foot segment. Okay, but if we don't have ankle dorsiflexion, if we don't have the mobility there, what we'll typically see is this, like you see here, this internal rotation of the tibia to try and drag the foot segment into internal rotation or into pronation where we're dropping that arch. That doesn't represent honest ankle dorsiflexion. That's an in-phase strategy to try and get that knee to the dowel. So the goal is to get the knee to the dowel, but how are they getting there? And does that represent that the motion is coming from the ankle? If you see this in-phase strategy of the tibia moving internally to drag the foot into internal rotation and pronation, that represents that the motion is not coming from the ankle. We're distributing some of that movement into the foot. So we're not concentrating that movement or mobility at the ankle. Okay, so in a rehab scenario here, we need to use strategies where we prevent or delay that internal rotation of the foot segment to try and concentrate that movement at the ankle. Okay. And in future videos, we'll go through some of those rehab strategies. So that would represent an in-phase movement strategy or coordinated strategy, where both segments, neighboring segments, are moving into internal rotation. We can see the same thing with ankle plantar flexion here. This would obviously bias more of a force production strategy, where we're looking at the general load capacity, the force production capacity of the ankle plantar flexors here. Okay. we're seeing how the tibia is helping to facilitate a certain behavior at the foot segment. When we're looking at ankle plantar flexion, we want the foot to express more of a supinated behavior, to represent more of a rigid foot behavior, but also to facilitate some load into the first metatarsal head as well. Okay, so we want a rigid lever for push off. It's going to be very difficult for us to be able to get through full range ankle plantar flexion if we have more of a pronation bias, or if we're stuck in a more of a pronation bias at the foot. So there's nothing wrong with pronation. It's more about the capacity to transition from pronation, dorsiflexion into plantar flexion, supination. If we don't have that capacity, then we lack general variability around the foot and ankle segment, and we need to organize our rehab strategies to restore that variability. Okay. So when we're looking at ankle plantar flexion, we want to see that coupling of the external rotation of the midfoot, the supination of the midfoot. We want to see this big toe extension, which will help keep that distribution of load into the first metatarsal head. But we generally want to again see this tibia staying in the sagittal plane. Okay, that would represent for us a nice, clean or honest ankle plantar flexion, where we see this supination of the midfoot, this distribution of load into the first metatarsal head, and this inversion of the calcaneus at the top of the motion. When clients lack good ankle plantar flexion load capacity or force production capacity, generally what you'll see is this, either this inability to supinate and plantar flex the ankle, where they stay biased towards pronation, or what you'll see is this very quick transition into supination, where they lose that load through the first metatarsal head and they deviate over to the lateral board of the foot. So this is what we're looking for here. Can we actually keep that load through the first metatarsal head, invert the calcaneus, keep the tibia in the sagittal plane? Okay. And the next strategy here, you're going to see an inability to invert the calcaneus because the midfoot is staying in a pronated position. So we're struggling to generate enough force through the ankle plantar flexors to invert the calcaneus. What you're also seeing in this scenario now is what we're looking at. We're looking at here at this this in-phase strategy, where you could also see it. You might see both. You might see this inability to invert the calcaneus through the ankle plantar flexion range of motion, or you'll see this very quick transition into supination. But as you'll see here, you'll see the tibia is moving into external rotation to drag the foot into supination, and we lose that distribution of load through the first metatarsal head there. Okay, so both would represent similar strategies, an inability to plantar flex the ankle, but we're seeing an in-phase strategy here where tibia is externally rotating to drag the foot into external rotation. Looks like we're getting a nice bit of plantar flexion, but we're not really getting much plantar flexion at all. It's just the tibia dragging the foot into supination. Okay, but it does represent for us that the ankle plantar flexors don't have that force production capacity. Okay, so two ankle range of motion assessments on both ends of the spectrum, looking at ankle dorsiflexion and ankle plantar flexion. But what we're looking at here is the coordination strategy of how the neighboring segments are interacting with each other and what that represents for us. This would represent an in-phase strategy for us, which represents less variability in the capacity to dorsiflex or manage forces, or the capacity to plantar flex and produce forces acting on the ground in this scenario. This would guide us in how we structure the interventions to restore variability back to the foot and the ankle. These are not the only assessments that we will use. We will have to look at the rear foot, midfoot, and forefoot with a little bit more focus as well. If this is a client with a foot and ankle complaint or movement limitation or pain experience, but we would still look at these assessments even with more proximal complaints, because again, when we're managing forces from the external environment, it's ultimately the end point of the limb that has to manage those forces first. So we do want a certain amount of variability in both the capacity to dissociate the tibia and the foot segment, but also the capacity to produce force through the foot and ankle segment as well. Okay, so this is how we structure our assessments. So we look at the interaction between segments and we describe them through the capacity to either concentrate movement at a particular joint segment, or if we're using a in-phase strategy to drag neighboring segments into the same direction. Okay, and you can see both these representations through ankle dorsiflexion and ankle plantar flexion.